Good morning, everyone. I want to thank Smile Train for the opportunity given to me to share my thoughts this morning. I'll be sharing my thoughts on Cleft, Palate, Determinants of Health to the Rescue. I've done my acknowledgements. I'm going on to the introductions. Then we'll together look at social determinants of health and how social determinants of health can come to the rescue. In terms of definitions, we know that cleft lips and palates are malformations defects in the mouth that occur very early in pregnancy while the baby is inside its mother. Cleft palate results when the tissue does not join together as expected in the development. And cleft lip and palate are splits or separations in the face and mouth of a baby that occur while the baby is still developing. And so this is, we all know this is what cleft lip looks like, and it's a physical separation of the two sides of the upper lip and appears as narrow or wide opening or gap in all layers of the upper lip. This separation can include the gum line or the palate. Also for cleft palate, it's a split or opening in the roof of the mouth, and it can include this hard palate or the soft palate and can be associated with cleft lip. I try to look at what the prevalence of cleft is in Nigeria so that we can better appreciate why the social determinants of health are important in the prevention of occurrence of clefts. I looked at a data published in 2014 by Butali et al. And the Nigeria Crown collaboration. They looked at Smile Train data from 6 geopolitical zones in Nigeria, and the data they looked at span September 2006 to June 2011, and they analyzed it. And a total of 2,197 cases were identified, which gave a prevalence rate of 0.5%. Now, we may think that 0.5% is small, but these are only those who present in the hospitals. As small as it is, if we convert 0.5% into absolute number, it is still a large number, bearing the scarce resources that we have to manage clefts. I also looked at a study by Akimoladun et al. That was published in 2017, and it gave us a regional prevalence rate. And if we look at this chart, we could see that the highest is from the southwestern part of the country, followed by south-south, then southeast, northwest, north-central, and we have the least from the northeastern part of Nigeria. Now, looking at this, I asked myself, is there something in the southern part of Nigeria that is making us see more? Is it something about our way of life? Is it something about diet? Is it something about our genetic makeup? And so these are the thoughts that gingered my thinking about looking at the social determinants of health coming to the rescue. So we all know how clefts are formed or developed. I'm not going to spend time looking at this because we all know, but I brought this up for just to refreshing our memories and to say that it is with us and we need to understand how it comes about, especially for those of us who are the primary contact with mothers when they have cleft, babies with clefts, and they're asking questions. We need to know how clefts are formed so that we can explain to them why and how it happened. Then we'll look at the causes of clefts, lips, and palates. And when discussing the causes of clefts and palates, we need to ask ourselves, is it a syndromic cleft or a non-syndromic cleft? A syndromic cleft is that which has other symptoms apart from just this, the cleft. And so for those who have syndromic clefts, their own line of management is much more involving than those who have sporadic clefts. And sporadic clefts are those that didn't have any symptoms attached to it. And the causes of the non-syndromic orofacial clefts are thought to be multifactorial, which means that a combination of genetic and environmental factors contributes to the development of the clefts. And majority of these have no identifiable cause the skin during the first trimester. In addition to the mother having diabetes mellitus prior to pregnancy. And it's been shown that do decrease the risk for developing cleft lip and palate in the child. So these are the social determinants of health. So we are going look at what social aids. Also, social determinants of health have been defined as factors apart from medical care that can be influenced by social policies and shape health in powerful ways. This is by Braveman and Gottlieb 2014. And CDC in 2021 described social determinants of health as the complex interrelated social structures and economic systems that shape these conditions. Healthy People 2030 defined social determinants of health as conditions in the environment where people live, where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So what this means is that the social determinants of health are shaped by distribution of money, power, and resources throughout local communities, nations, and the world. And differences in these conditions lead to health inequities or the unfair and avoidable differences in health status seen within and between countries. So what are the factors that influence health? Medical care, social factors, our behavior, what we do, the environment in which we live, How much of pollutant is there in the environment? How safe is the environment? We have physical influences, and of course, the genetic makeup influence our health. So if we look at what determines health, genetics takes 30%, patient choices 40%, medical care 10%, social 15%, environment 5%. Now we are going to go back and look at the causes of cleft lip and palate that we had discussed earlier and see how these interplay. If we look at the causes, now the causes of non-syndromic orofacial clefts are thought to be multifactorial, which means a combination of genetic and environmental factors. Also, it's been found that the strongest risk factor for developing a cleft is family history. Beyond that, the behavior, the choices that we make. Maternal smoking is a choice, it's a behavior. Consumption of large amounts of alcohol, it's a behavior, it's a choice. Certain medications taken during first trimester, it's a behavior, it's a choice. Maternal diabetes mellitus, that is genetic. So if we go back to look at that, so if we add patient choices with our environment cum social, we would see that like 90% of the causes of clefts are in between the genetics, the environment, patient choices, and behaviors, interactions. And it's been shown that there's a decrease in the risk if the mother uses prenatal vitamins and folic acid. So it means the medical aspect is also a key determinant. Does she have access to antenatal care? Or before antenatal care, is there a prenatal service for women to access? And so all of these domains influence the outcome of health. Economic stability. How stable is the economy? In the last 1 year, we know the world's economy has really gone down because of COVID-19. And so do people have what it takes to stay healthy? Yes, they want to eat healthily. Do they have the resources to do so? Yes, they want to access health care. Do they have the resources to do so? What about education? The girl child is always on the receiving end. When resources are scarce, who should go to school and who should not go to school? What about health and health care? There are different access problems. Is it financial access? Is it physical access? That is, how far or how near that health facility is to where the woman is living. Also, our social and community context. We know that in the community, we have key gatekeepers that determines what happens at some point in time, especially when we are looking at a pregnant woman and what she does in pregnancy, where she goes in pregnancy, what kind of care she receives. Now, this one of the key gatekeepers are the mothers-in-law, who ensures that their daughters-in-law follow the family tradition of what should be eaten, what should not be eaten, of when she should access healthcare. And in the part of Nigeria where I come from, and I think that also apply to most part of Nigeria and Africa, is that a pregnant woman doesn't go for antenatal care until it's obvious that she's pregnant. But the key decisions, the key developmental stages would have passed by the time she accesses antenatal care. So our community context, our social context also are key determinants. What about the neighborhood and our built environment? Is the environment green enough to have good aeration? What about the living standard? The environmental health professionals tells us what the dimension of a room should be, the number of people that should sleep in a room. Now, economic stability will determine whether many people will be able to afford the kind of room as specified by the environmental health professionals. And so all of these determinants, education, is there access, is there quality, healthcare and quality, neighborhood and the environment, social and community context, and economic stability. We can see the health outcome of all of this. And looking specifically at cleft lip and cleft palate, we can see that the health outcomes starts with morbidity. The child is not fine. The child cannot eat properly. The child cannot suck. And we know that in the first 6 months of life, exclusive breastfeeding is what is recommended. But a child with a cleft will not be able to do that. So feeding functionality is limited for such a child. We have talked about the finance. The healthcare expenditure is huge. How much of the family resources is being committed to this? And so, depending on what the financial status of the family looks like, seeking medical care would also be delayed, or more delayed than necessary because the resources are not there. And ultimately, even the mother is affected psychologically, emotionally. Everybody in the family is affected. And so it gives a lot of emotional burden to everybody. And so, having said all of this, I'm sure the question on all our minds is, okay, we know about cleft lip, we know about cleft palate. You have told us what social determinants of health, what they are. Now, I'm sure all of us are asking, okay, so what's next? What is next is a rescue mission. Yes, we already have children who have clefts, whether of the lip, of the palate, or both. Now, we don't want to continue to see them. We want to reduce the occurrence to the barest minimum. And that is where the social determinants come in as the rescuer, as the building block of our rescue mission. And if we are going to do that, we are going to look at 3 things. The first is that we need to improve the conditions of daily life. The circumstances in which people are born have to be improved. Do women have access to skilled birth at delivery? Where are the children born? Did the mother have the benefits of prenatal care? Now, prenatal care is the service that the woman has to go through ever before she becomes pregnant. That is where genetic screening will be done. That is where if there are risk of a child developing any abnormality, that is the time to identify. But unfortunately, many people, that service does not exist in most places. Where it exists, people don't know. And so most women never access prenatal care ever before they get pregnant. And so when they get pregnant, at what point do they start antenatal care? Oftentimes, the first 3 months, they are not there. And that is the most important period in any pregnancy. So we need to improve the conditions in which people also grow up. We are talking about the environment. How safe is our environment for children to grow up in? How safe is the environment? Can they crawl safely in that environment? And we'll be happy that our children are crawling in that environment. How safe is that environment? We need to also look at where we walk, because our environment in terms of air quality is important. In terms of overcrowding, it's important. Also, can people age gracefully? We also need to tackle the inequitable distribution of power. And when we talk about power, it means who holds the ace, who takes the decision in the family. Can the woman take the decision herself without the permission of the man? Is she sufficiently empowered to be able to identify that there's a problem and she takes a step to solve that problem? Who has the resources? And these are the structural drivers for our daily life, globally, nationally, and locally. And then we have the problem on our hands. There are children with clefts. I want to appreciate Smile Train for the great work that they are doing in putting smiles on the faces of the children and on the faces of their parents, especially the mothers, because I know what mothers go through. As I'm presenting this, my mind is flashing back to the kind of psychological emotion that I have seen on faces of mothers when they bring their children to the clinic. Many times they burst into tears and they ask the question, is there a hope for this child? Would this child ever look normal? Will I be able to showcase this child as my child? So mothers keep asking these questions. And we thank Smile for helping to answer some of these questions and putting smiles on the faces of these mothers. And so we need to continue to measure the problem. As Smile is helping to bring smiles on the faces of the children and the mothers, are we having more babies coming with clefts? We need to know. The prevalence I cited earlier that we got from Smile centers, there are many who will never get there. And so we need to understand the problem. We need to identify and be able to say, this is the magnitude. Even if we want to form an advocacy group to the government, we need information, we need facts. So we need to measure the problem. How large is the problem? We also need to evaluate action. Yes, Smile Train have been doing wonderfully well. Is there a way we can help them do it better? Is there something else that we need to do? How do we recruit the babies who benefit from this? So we need to evaluate action. we need to expand the knowledge base. By knowledge base, we need to go down into the community to talk to mothers. I'm not sure how much of Clefts, I'm not sure of how much of Cleft information that mothers get during the different health talks at the antenatal clinics. I am not sure. At least I have attended some sessions, but cleft palate was not, the cleft palate, cleft lip was never mentioned to my hearing. And so we need to expand knowledge base. We need to talk to the girls in school as they are growing up, so that they know, so that they can talk to their mothers, their aunties. And so when they're becoming young adults themselves, they'll be able to prevent some of the predisposing factors in terms of smoking. They may not smoke actively, but they may be passive smokers. So we need to expand the knowledge base, not only the knowledge base of predisposing factors, also the knowledge base of where help can be sought, of health-seeking behavior, where people can go, so that the lives of these babies are also not put in jeopardy. We cannot rule out the fact that some of these babies will just be left to die somewhere because parents don't know where to go. We also need to develop a workforce that is trained in social determinants of health, who would help in raising public awareness about the social determinants of health. I know that in this part of the world, if we wait for government to do everything that we have identified in the social determinants of health, then we may not move forward. But this trained workforce can let people, will raise awareness and then show people that they can do something for themselves. The things that they can do for themselves without waiting for government or external bodies to do. These threefold measures will help us reduce drastically the prevalence of cleft lip and palate. Thank you for listening. Over. Hello? Hello? Hello?
Thank you, Professor. Such a magnificent presentation. We all learned a lot about it. Just a reminder to our participants that we have the Q&A for the questions. The presentation of the professor was very clear, very educative. Congratulations. We have the Q&A for questions. We have the chat where I can say, Professor, everyone is being very thankful to the amazing presentation. We have here a commentary who's writing, said, benevolent presentation, very educative presentation, well done. Thank you, Professor. We're waiting for more questions to come on Q&A. Soon as they come, I will tell to the professor and she will be more than happy to answer. Since they're not coming yet, I have a question myself, Professor, for you. Was the saddest story and the happiest story that you ever lived with a cleft patient?
Yes, I had a few of them. The one I can remember vividly is an adult. By the time I saw her, she was already an adult. She has had the cleft repaired, but she still has issues with her speech. She had what we call rhinolalia, and I had to work with her. And I know that even as a young adult that she was then, she still has issues with self, now the word has just escaped me. She couldn't do as much as she would love to because of, I mean, when she speaks, everybody turns to say, who is speaking? Who is that? So that limits how much she can go. A few of the mothers that I saw, there was a particular one that was just, I mean, just shedding tears and saying, didn't see them post-operative, during the post-operative period. But I know that it's a lot of psychological trauma. And I think in caring for such children, we need to expand the Hello? I have a question here.
Yes, Professor.
Okay. I have a question.
Yes, we have a question for you.
Yes.
Mm-hmm.
It says, who among the Cleft team can provide this service? I think to an extent, we all can do a bit of it, but the team that can do more is the primary contact of the mothers, the primary contact. But then we need to engage people who can do, who just have this as their own duty. Otherwise, the duties of the other team members would, we will reduce the effectiveness of the functioning of the other teams if we ask that they should also add this on. So, but we can do a bit now that we know we can talk about it, and at least so that they have an idea of why or how and what they can do. But we would do well to include people on our board, on our team that can do this. Yes, I can see a hand. Yes, 2 participants raised their hands. Yeah, I can't see them so that I could have called them, but please feel free to ask your question.
I think one of the hands is actually yours.
Oh, okay.
The other is of our moderator.
Okay, okay.
Yes. I think I also have another question, which is when we look at the different spectra, when it comes to government and smeltering and the partner support, how can the three come together to really raise awareness about the support systems that are available? how can we challenge the government to come in and step in, especially to support the patients?
Yeah, thank you very much. How the three can come together by working with community engagement specialists, so that they themselves the team primarily would have some training in community engagement, and then the community engagement experts would help in facilitating entry into the community, getting the group of people that the team will be talking to. So primarily the team needs some training in community engagement, how to identify who to talk to, how to decide the level of engagement that we want people to be involved in and all of that. And then working with the experts, enter into, gain access to whichever community we want to go to. And I'm using the word community loosely now. Community, I'm using community not as a town or a village, but I'm using it to mean a group of people that are of interest to us, whether mothers or even policymakers or fathers, as the case may be. So the starting point is the team members, the team themselves need some form of training on engagement for these activities, and then working together with the community engagement experts, be able to plan how to do all these awareness and sensitization programs and where to go when the need arises. Over.
Thank you so much for that answer. Dear guests, we continue to invite questions. We do have quite an amount of time with our amazing panelist today, our amazing speaker today. And there's a lot to learn on research and the data collection that we can use to support the awareness creation. So please keep your questions coming on the Q&A and we'll be able to respond to them. But meanwhile, as we wait, you have spoken about the need for data and some of the challenges you may have experienced in this data collection. Maybe you can expound on some of the top 3 strategies we can apply very easily as partners in support of the data collection and management.
Okay, thank you very much. The first step is the awareness creation. The higher the awareness, the more people will present to us. So if we are able to raise awareness at the demand side, because those of us, the SMILE trained team, we are the supply side. If you're able to create demand awareness on the demand side, then people would come out to seek help. And so when they now come to seek help, we need to look at our data system. How is it now? How do we capture our data now? Are there some challenges? Where is the first port of call that we collect data? Or are we depending on secondary data from somewhere, or we are the primary contact? So what we need to do is to study the existing data collection system and see if can we do it better? Can we introduce something else to make sure we get more data? Can we have a link person at the community level who will be like a form of surveillance officer to be able to pick those in the community that are not coming out, that would encourage them to come out. I think these are some of the ways we can improve our data collection. And of course, proper record keeping is key, so that we don't, when they come out, we don't miss them, as it were. Over.
Thank you so much, Prof. Thank you, Prof. Any other questions from the floor? I see your presentation was so engaging and involving, and indeed it's quite the challenge that you have presented to all of us, and we truly, truly appreciate you. And I'll give it back to our moderator, Dr. Preciusa, to close the meeting if there are no other questions. Oh, sorry, I see there's one question that's come through. So, very well done presentation. Is the cleft prevalence by region?
Yeah, the question is the cleft prevalence by region reflected in the health sector statistics? Not really. You will not, it will not pop up in your face, except you specifically go to look for it. You won't find it. Because what we are likely to see in health sector statistics are data that has to do with what is at the front burner right now. We are likely to see data about communicable diseases, key communicable diseases, over and above these kind of conditions. So except we specifically look for this data, we are not likely to see it pop up as it were. So maybe this is one of the places where we need to have our input to ensure that when each of our countries are collecting the DHS, to ensure that such data is included. Because if it's not in the data, there'll be no provision for them in the budget or in making sure that services are available for them. Over.
Thank you so much, Prof. Thank you so much for that wonderful response. So indeed, there is quite the need for data that is able to cascade to the local level, if only to have informed decisions on policy. Any other questions? Right, great. Thank you so much, Prof, once again for your time. I appreciate our moderator, despite the technical hitches that we have possibly experienced. We are grateful for your time and the expertise you have provided.
Thank you.
I would like to appreciate all our attendees and our panelists for coming today, our teams from the West African College of Surgeons for making these meetings a reality, because they are insightful and they do challenge our thought process as we grow our programs across Africa. This is the Telecleft Virtual Lectures brought to you by SmileTrain and the West African College of Surgeons. We look forward to meeting with you again on the 25th of October for another interesting session. We will meet here again at 11 a.m. West Africa time, 10 a.m. GMT, and 1 p.m. East Africa time. For now, we wish you a wonderful week ahead, a happy new month, and blessings to all the projects and works that you undergo or take up. Have a lovely